management of intraoperative hypertension in previously normotensive individuals. So we'll start with the definition of perioperative hypertension. Perioperative hypertension is defined as a systolic BP of more than 40 millimeters of mercury greater than the baseline, or more than 20% of the patient's baseline value, or any value of systolic BP more than 200 millimeters of mercury. Perioperative hypertension is further classified as pre-op hypertension, intraoperative hypertension, and postoperative hypertension. We will be looking at intraoperative hypertension, causes and its management. There are two categories of normotensive patients who fall under the category of intraoperative hypertension. One is normotensive patient who develop intraoperative hypertension due to any stimulus, and the second class of people are normotensive individuals with left ventricular hypertrophy, like athletes who develop abnormal increases in blood pressures during exercise or exaggerated hypertensive response to any physiological stimuli. Coming to the causes of intraoperative hypertension, we can divide them into three. The first one is due to that of increased sympathetic tone. The second one is due to any inadvertent drug overdose. The third is miscellaneous causes. Coming to those causes that are due to increased sympathetic tone, it can be due to any airway manipulation like laryngoscopy or extubation. It can be due to inadequate analgesia. It can be due to a lighter plane of anesthesia. Hypoxia and hypercapnia also can increase a sympathetic response. Any surgical incision or bladder distension can cause increased sympathetic tone, thereby causing hypertension. Next, coming to drug overdose, any inadvertent intravenous injection of adrenaline, for example, while local infiltration of lignocaine with adrenaline, any inadvertent intravenous ephedrine or ergometrin can also cause intraoperative hypertension. Other miscellaneous causes include hypervolemia, that's seen during aortic cross-clamping, pheochromocytoma, and malignant hyperpyrexia. Next, coming to the management, we'll see the management of hypertension during laryngoscopy or tracheal intubation. During laryngoscopy or tracheal intubation, there is stimulation of the sympathetic system and hormonal release, which causes increase in heart rate and increase in BP. This increase in heart rate and BP starts within 15 seconds of laryngoscopy, and it is maximal after 30 to 45 seconds. This response is exaggerated, especially in rapid sequence inductions. It is very dangerous in those with coronary artery or cerebrovascular disease, where this tachycardia and hypertension cannot be tolerated, and it can cause a reduction in the left ventricular ejection fraction, can even lead to intraoperative myocardial infarctions. So one way of managing this is to limit the laryngoscopy to 15 seconds or lesser. Another way is we can give pharmacological treatment. These are the following drugs that can be given 1 to 2 minutes prior to laryngoscopy to blunt the sympathetic response. First, we'll see opioids. We can give low-dose fentanyl 1 to 2 mics per kg, or remifentanil of 1 microgram per kg, or sufentanil dose of 5 to 7 mics per kg, alfentanil of 30 to 100 mics per kg. Other than opioids, we can even give lidocaine IV of 1.5 milligram per kg, or a topical infiltration of lidocaine. Alpha plus beta blockers like esmolol, which is an ultra-short acting alpha plus beta blocker, 1 to 2 milligram per kg, or labetalol, 0.15 to 0.3 milligram per kg. Labetalol is usually given in 5 milligram increments of IV. If these don't work, we can even go in for nitroglycerin at 50 to 100 microgram, or sodium nitroprusside infusion of 0.5 to 1 mics per kg per minute. Next, coming to surgical causes, where lighter planes of anesthesia can cause an increase in intraoperative hypertension. To avoid this, we can use a balanced technique of anesthesia, whereby there's a combination of nitrous oxide, adequate neuromuscular block, opioids, and volatile agents. To reduce the sensory stimulation caused by sensory input, we can increase the concentration of either of these, particularly volatile agents, so that the sensory stimuli is reduced. We can even go in for a combined epidural with a light general anesthesia, or lumbar or thoracic segmental epidural blocks during abdominal or thoracic surgeries can also reduce the sympathetic stimulation. Now, coming to special scenarios, The first one we'll see is due to hypercarbia. A very common scenario is during laparoscopic surgery where carbon dioxide is insufflated for the creation of a pneumoperitoneum. Carbon dioxide insufflation by itself, it will cause hypercarbia because of diffusion of carbon dioxide into the systemic circulation. This causes release of adrenaline and noradrenaline, which in turn causes an increase in heart rate and mean arterial pressure, and thereby causes an increase in the cardiac output. Pneumoperitoneum itself, due to mechanical compression, can cause a reduction in increase in the venous capacitance and increase in the systemic vascular resistance. The uh, by it can transiently reduce the venous return and reduce the left ventricular end diastolic volume, and it can increase the systemic vascular resistance, thereby increasing the afterload. Both of these factors can cause an increase in the intraoperative mean arterial pressure. Usually in such patients, in healthy normal patients, the left ventricular ejection fraction is maintained. To reduce this response, we can first, immediately after induction of laparoscopic surgeries, we can put in a urinary catheter and a nasogastric tube so that the distension of bladder is not one of the reasons for intraoperative hypertension. Next is we can increase the minute ventilation to wash out the excess amount of carbon dioxide. Third is to use a balanced technique of anesthesia. We can even give a multimodal analgesia to reduce any potential surgical stimuli. We can give local anesthetic infiltration of the wound. If all these don't work, we can go in for pharmacological measures like using vasodilators and alpha-2 agonists like clonidine or dexmedetomidine. But potential complication with using intraoperative clonidine and dexmedetomidine, especially for short procedures, is that they can cause post-op sedation, which can be dangerous if we're extubating the patients on table. The next scenario we'll be seeing is about aortic cross clamping. This is a scenario where the descending aorta, especially the thoracic segment, when it is clamped for aneurysm repair, there is a increase in the mean arterial pressure above the cross clamp by almost 40%. This causes an undue stress on the left ventricle, and so we need to use a Swan-Ganz catheter for monitoring the pulmonary capillary wedge pressure to detect any impending left ventricular failure. Um, Most patients won't be able to tolerate such uncontrolled hypertension, so we need to use vasodilators. But one complication that we need to keep in mind while using vasodilators is that they can reduce the collateral perfusions to the lower extremities, especially to the spine, because any reduction in the mean arterial pressure to the spine can cause a paraplegia postoperatively. So we need to be careful in these patients. The next scenario is pheochromocytoma. Um, uh, these are catecholamine secreting tumors that arise from the primitive neural crest. Almost 10% of such patients are asymptomatic. So we can see hypertension during the tumor handling. The treatment for such cases is to deepen the plane of anesthesia. We can give sodium nitroprusside infusion, or we can give phentolamine infusion, nitrates, and nicardipine. Usually, this uncontrolled hypertension results when there is inadequate preoperative preparations of such patients. So we have to make sure that they are alpha and beta blocked preoperatively. Next, coming to autonomic hyperreflexia. This is usually seen in patients with a chronic spinal cord transection. This is initiated by visceral or cutaneous sympathetic stimulus below the level of the transection. Such stimuli are usually, the most common stimulus is usually the distension of a hollow viscus like a full bladder or a loaded rectum. There is sympathetic activity that flows via the splanchnic outflow tract, which causes vasoconstriction below the level of the transection. This causes hypertension and a reflex bradycardia in such patients. Intraoperatively, if we see such reactions, if we can give regional anesthesia to such patients to block that sympathetic outflow, and we can treat the cause. Like for example, if it is bladder distension, we can catheterize the patient. If we are suspecting it is due to the rectum loading, we can perform rectal evacuation. In GA, if the patient is in GA, we can deepen the plane and we can treat them with antihypertensives. The last scenario is malignant hyperpyrexia. which is a rare but a potentially lethal genetic condition, which is due to impaired calcium homeostasis, and it can be triggered by agents such as succinylcholine and volatile anesthetic agents. The initial signs of malignant hyperpyrexia are increase in the EtCO2 and an inappropriate tachycardic response. This is followed by hyperpyrexia, hypertension, hypoxia, and acidosis. There is also due to the sarcolemmal rigidity, there is hyperkalemia, which can cause potential arrhythmias and myoglobinuria. So treatment of this condition is to stop the triggering factors, like immediately discontinue the volatile agents nitrous oxide and give 100% oxygen. If possible, we should change the entire circuit. The definitive treatment is giving IV dantrolene sodium, which is diluted in alkaline mixture of mannitol. The dose of dantrolene is 1 to 2 milligram per kg. Then this is followed by active body choline. For hyperkalemia, the treatment is dextrose and insulin infusions. If this doesn't work, we can go in for a hemodialysis. We can also give other supportive therapy like IV antiarrhythmics, electively ventilate the patient, and until the symptoms settle down. So that's all I have prepared, sir.
Very good. This is a question which this sort of questions be given to test your knowledge to compile the conditions which produce intraoperative hypertension, especially in an hormone-sensitive patient, based on the surgical or the anesthetic causes. Okay? So these answers will not be available ready-made in any textbook.
Yes,
So
sir.
you have to go through all the scenarios which you have encountered and then compile it. And for that, we have prepared a very nice thing. One more thing you can add to this is the thyrotoxicosis, which also will produce a severe hypertensive response.
Okay.
Undetected form pheochromocytoma is one of the reasons for intraoperative hypertension. And similarly, patients with what is called subclinical hyperthyroidism, they also can have a thyroid crisis on the table, which will also mimic like a malignant hypertension or the other cholinergic crisis like this, and that also can add to the thyroid crisis.
Okay.
So I'll just show you the slides which are very short for this particular